Another VCU Health seminar here at Lewis Ginter Botanical Garden. We're happy you're joining us here tonight on this rainy day. I'm Elizabeth. I'm an event coordinator at VCU Health. Tonight we have Dr. Bergman presenting Be Your Own Health Advocate. We'll start with a presentation by Dr. Bergman, which will last about 45 to 50 minutes, and then we'll open the floor to questions for the last 10 to 15 minutes. If you have a question, we ask that you please write it down on a sheet of paper, and I will come around at the end of the presentation and pick it up. While our speakers are reviewing the questions, we will draw for our raffle winner, which is umbrella, fitting for like that quick little chunk of rain we got. If you checked in at the front door, you're registered for the raffle. Now a little bit about Dr. Bergman. He is a board certified in internal medicine and geriatric medicine. He attended medical school at the University of Virginia in Charlottesville, Virginia, and his internal medicine residency and geriatric medicine fellowship at the Eastern Virginia Medical School in Norfolk, Virginia, where he specialized in post-acute care and care transitions. He is an assistant professor at VCU in Richmond in the Division of Geriatric Medicine, where he's focusing on improving transitions of care throughout the VCU Health system. Dr. Bergman is actively involved at the state and national level of AMDA and AGS. His research interests are transitions of care, care coordination, geriatric education, leadership, and advocacy, neurodegenerative disorders, and clinical applications related to ketosis. On his spare time, he enjoys spending time outside with his wife, Becca, and two sons, Eric and Zach. Hobbies include cooking, watching college football, and traveling. Please help me welcome Dr. Bergman.
Thank you so much, appreciate it. So I also enjoy cutting down bamboo. I just moved into a new house and I spent 10 to 15 hours cutting down probably 200 or 300 bamboo. So if you know a panda in the Richmond area, you got a great, so yeah, it's going to be a 2-year project, I think. So. Thank you for the advice. So if anybody wonders what the J stands for, since I didn't put all my names up there, it's Johan. I'm originally from Sweden, hence all the names. So bear with me, I have a little bit of an accent, so you may notice it at one point. So before we get started, just to set the stage for this talk, do we have any healthcare professionals in the crowd? Nurses, pharmacists, doctors, retired counts? Anybody? All people. That's fair enough. How about anybody that has experienced a transition, either personally or a spouse or a close family member? And by transition, I mean gone to the ER, been hospitalized, gone to a skilled nursing facility. Anybody within the last 6 months? Okay, very good. So this is what we're going to be talking about throughout our talk today, so bear with me. So I have to put conflicts of interest up because we're associated with an academic center. So these are potential conflicts. None of them are directly related to our talk tonight. I just have to mention them. The only thing I will say is that electronic medical records are getting increasingly sophisticated and trying to capture your story so that we can help in these transitions. So you will see over the next 5 to 10 years, there being much more than just a medical history being captured. So functional status, how are you doing at home? Where do you currently reside? Independent living, senior living, assisted living? Are you in a long-term care facility? So don't be shocked over the next 5 to 10 years whether people start asking you those questions. It's all to help with these care transitions. It's really important information, so just put that caveat out there. And AMDA is American Medical Directors Association. It is the national organization for those that are interested in post-acute long-term care medicine. So today we're going to be talking about care transitions within the U.S. healthcare system. We're also going to be talking about electronic medical records and are they good at sharing data? We'll talk about that. Transition models that work. So some of these models were proven in the literature over 20 years ago. I think it's important just in the context of this presentation that you all see some of that data. So we'll be discussing that. And then the last part of the presentation will be a little bit related to the handout that I picked out. And so, I picked out and handed out. There's a few more copies up here. We probably have some more at the back, but It's in regards to what you should carry in the wallet and important information to have readily available. So I work within the VCU Division of Geriatric Medicine, and the chair is still Dr. Peter Bowling. He has been chair for over, he's been in the Richmond area for 35 years. So many of you may recognize his name, but he has been leading the division, and our current offices are housed on the Bergman Avenue. And we have a wide range of presence throughout Richmond. My presence is in the inpatient consult service. So we do automatic trauma consults on all patients, medicine consults on all trauma patients that go to VCU. If you're over the age of 65, you will meet a geriatrician when you go downtown. We will also see you in the skilled nursing facility and long-term care as part of the care continuum. That's where the efforts that I am leading, but also the health system at the top level are interested in what happens to you before and after you leave the hospital, no longer just what happens in the hospital. So, talk a little bit about care transitions. This number represents how much we spend per person in the United States per year on healthcare related expenses. This represents your average out-of-pocket costs. Now, taken across the whole population, of course, so some of you will have more, some of you will have less, but that's a lot of money.
Would you call out those numbers?
I'm sorry, yeah, so 9,364, and this is data from about a few years ago, 3-4 years ago. 9,364 is the amount of money that we spend in the United States as a collection per person per year. 1,034 is the average out-of-pocket costs. Multiply those numbers by our most recent census data, and you get $3 trillion. And just as a reference, our annual GDP is 19 trillion. So if you do your math quickly, and the mathematicians here, this is about 16%, and expect it to go higher. So why do I mention this? This seems kind of irrelevant to being your own healthcare advocate. Well, the reason it's important is these numbers are predicted to go higher. And I'm sorry, I don't know if the pointer works here, but I will highlight the last bar there is 2027. That's not that far away from now, 8 years from now. And we are expected to be an annual growth rate of 6% at that time. And these numbers will continue to go up. That's why you're seeing this conversation about healthcare spending. Is Medicare model sustainable, all of this. So how does that relate to care transitions? Well, let me show you some numbers here. So this is data from almost 8 years ago now, 9 years ago. 1 in 5 Medicare patients discharged from a hospital in the United States will be readmitted within the next 30 days for some reason. Okay? That is 2.6 million seniors readmitted every month from those hospitalized. Just take those numbers into account, that's a lot. At a cost of over $26 billion of preventable readmissions that we could, through better communication, reduce. Now, you might say 26 billion, you just said $3 trillion, it doesn't seem like that would even touch, but it's a small piece of the puzzle. So I just want to make sure, if we tackle each one of these small pieces, eventually our growth rate will not go up by 6%, but maybe start to go down. So this represents that's 44 billion, if anybody was interested in how many zeros there are there. So that's the true cost of so 26 billion that I just showed you was the direct cost for readmissions. But if you take into account other things like medication errors, complications from procedures that result from the readmission, the true cost is actually higher, $44 billion. So as we discuss and spend the next hour discussing care transitions, just want to make sure we're all on the same page about what is a care transition. So a care transition represents anything from your community-based care, which is in the left side, You will see home, I circled physician's clinic, your pharmacist, any diagnostic, wellness, fitness centers. Those are all community-based healthcare centers, whether they're your traditional clinic, whether they're in urgent care, those are all community-based. Then something happens. You go up this curve, your heart failure can't be controlled. You develop pneumonia that doesn't get treated with oral antibiotics and require hospitalization. You go into the hospital, which is the upper right. So most people that go into the hospital have no intention of staying there very long. They don't want to be in the hospital. Nobody likes being in the hospital. So we do a good job, we try, getting people out of the hospital as quickly as possible. But I'm not sure that most people in the hospital understand what happens in the next 30 days to you as a patient. So you will most likely go through some level of post-acute care, whether that's a skilled nursing facility, home health. You may end up, you can either go to a hospitality house, medical respite. There's a number of various locations that are not community-based resources where you end up for the next 30, 60, 90 days, 3 months, 6 months, a year. And the people in the hospital don't understand that that may be where you're heading. So just think about that while we talk about this. So what happens in care transitions? Why is this important? I mentioned it already in terms of cost, but what about specifically what could happen to you during a care transition as a result of a, I will say, healthcare failure of transition? It is not your fault, it is not the doctor's fault, it is not the electronic medical record, it is the collective, everybody, communication gaps, systematic issues. People mean well, but we don't have a great system in place. So 1 in 4 Medicare patients experience a, quote, complicated care transition. 1 in, I'm trying to do my math quickly, 1 in 5 approximately, right? 19% had an adverse event within 3 weeks. So 1.5 million people each year are harmed by medication errors. Many of these occur during transitions. So this is the key point number 1. Keep track of your medications. Okay, I'm going to talk about that. It's one of the most important issues during care transitions. Keep track of your medications. Changes made, medications you were taking before. What is somebody telling you? You're now going to be on what? Why? Okay, important for you all to know why. So, as we talk about solutions, and I'm going to show you some of the evidence, I'm going to talk about some solutions. Communication is the number 1 issue. So, key point number 2 from our talk will be communication. Number 1, medications. Number 2, communication. And this is not just between you and your doctor, it's also between your doctor and the primary care doctor, the person they're sending you back to after you leave the hospital. So just to recap all of that, there is a circle here. You stay in the hospital, you either go to a skilled nursing facility, you go to a rehab facility, sometimes you go to an inpatient facility, and then you go home. Some people don't do well, and what the hospitalization may represent the end of life for them, and they may be transitioned to hospice. It's important to understand preferences, your goals in care, your family members, and communication during all of these transitions. So keep that in mind. So I said we were going to talk a little bit about data sharing and EMRs. EMRs are electronic medical records, or EHRs, electronic health records. So let's see a little bit about how we do with data sharing. So if you look at an episode of care, so an episode of care may be defined in the literature as you presenting to your primary care doctor with a cough. You get diagnosed with some upper respiratory tract infection. The doctor tells you it's viral. 5 days later, you're in the ER because you've got a fever, blood pressure has dropped, and you develop sepsis, and you get admitted with a pneumonia. That pneumonia starts an episode of care in the hospital. It gets defined as index hospitalization, and then they track what happens over the next 30 days, 60 days, 90 days. So that is an episode of care. So if you look at episodes of care, most people see more than 10 doctors during an episode of care. Okay?
And $35 a copay.
Yeah, you're right. There is some cost associated with it as well. Keep in mind, out-of-pocket dollars I mentioned earlier in this presentation. 70% of Medicare patients saw more than 10 doctors in one of these episodes of care. 23, 1.25 almost, were discharged to a different institution. And what does that mean, institution? So that means that you did not go home. You did not go to where you came from. You either went to a skilled nursing facility or rehab, but you did not go home, and more importantly, you did not go home with home health. Somebody sent you somewhere else. So that's a high-risk transition. If you look at people with more than 2 chronic conditions, which I would argue in our older adults in this country, most people have more than 2 chronic conditions. Hypertension, diabetes counts. Hypertension, heart failure. Hypertension, prior stroke. If you've ever had coronary artery disease. You are likely to see at least 7 different physicians within 1 year of discharge from the hospital. So just start adding up these numbers. All of a sudden we're talking about 10 doctors in one episode of care, which could be 30 days, plus another maybe 7 more doctors in the next year. How are you supposed to keep track of all that information? How are your doctors supposed to know about what one is doing versus what another one?
3-ring binder.
Hope you have yours with you. So to have successful patient care, there are 3 elements. There's the doctor, there's the patient. There's a reason it's the largest bubble. You are your own advocate. So don't forget that. Doctor and the system, the healthcare system. What resources can we tap into? How can we help that doctor and that patient? Okay. So I'm just going to show you for illustrative purposes. This is the flow of information. Your primary care doctor has your medical record, whether it's still paper copy, whether it's electronic medical record. They have all your information. You have seen them for the last 25 years. You know them well, you know them by first name, you know all their kids. You saw all of them go to a college. So they know you well. What happens in the middle of the night at 2 a.m. when you get that fever and you go to the ER? Now all of a sudden your primary care doctor, you can't get a hold of the clinic, or it's after hours, you are told some nurse triage line and all you're told is, go to the ER. Well, when you show up in that ER,
you don't see your doctor.
You don't see your doctor anymore. Now, many years ago, before I was born, and I was born in 1984, if anybody's counting age, there used to be doctors that came into the ER. They would come in after hours. They would come in the middle of the night. They would see their patients in the ER. That doesn't happen anymore. Many reasons for that. Not a discussion for this lecture. But the important part here is this is an unknown person to you. They could theoretically have none of your history. Now, hopefully you have some information. Hopefully you're not confused, or you have a family member and you're able to share information. So that person may not have all your records, so keep that in mind. Now all of a sudden, you're with this strange person in the ER. It's loud, it's noisy, it's not a comfortable environment. The ER docs, by default, are here to make you better. They're very good at resuscitation. They're not so good at care transition and understanding outpatient care, okay? So by default, if you present to the ER, you have a high likelihood of being admitted to the hospital. So just keep that in mind. Now all of a sudden, you show up in the hospital. Now you're admitted. It's 4:30 in the morning. And all of a sudden, these strange doctors and nurses and other people in the hospital start rounding on you. They're waking you up. You're trying to get just an hour more of sleep. They're coming in, they're drawing your lab work at 3:30 in the morning. Awful time, but trying to get everything ready for the schedule of the hospital. Not your schedule, schedule of the hospital. So another thing to keep in mind. And there's a reason these doctors that I've illustrated down here don't have faces to them. You don't know them. They don't know you. but they know the story that's in the electronic medical record, okay? And then all of a sudden, they write these discharge orders that supposedly get sent to the primary care doctor. And then if you leave a good institution, you will leave with an appointment to see your primary care doctor in the next 1 to 2 weeks. That is because we're trying to connect you back to that primary care doctor, the one that actually knows you, so that they can review what happened in the hospital and how to make your next 30 days better, okay? So keep this loop in mind as we discuss some of these care models that were demonstrated in literature many years ago. So I'm going to go into some scientific evidence. These are all published studies. I'm going to try to keep it brief. Like we said before, if you have any questions, please write them down to the end of the talk. Happy to address them individually or as a collective, whatever we feel is helpful. So these are the 3 main models that are out there. So the Coleman model, the transitional care model by Mary Naylor, and Project Red, which was from Boston University. It's a group out there that are looking at discharge from the hospital. So, a lot of information, but I'm going to try to move through this quickly. Let me just keep an eye on our time here. Okay, we've got about 25 minutes left. So, Care Transitions Intervention was developed by Eric Coleman out of the University of Colorado. The key purpose here, I just want to highlight, are these 4 pillars that they thought was helpful. Keep in mind, this was like 1995, 96, long time ago, but these still hold true today, and this model has evolved. So, improved communication, medication reconciliation, timely follow-up appointments, and improved patient knowledge. So we're going to talk more about that. So what they looked at was to utilize advanced practice nurses in order to first meet you in the hospital, but then also meet you at home in the next 2 to 3 days after you leave the hospital, to make sure that what happened in the hospital, you understand what happened, you know what medications, and you actually got the medications from the pharmacy. Imagine that, somebody coming into your house to make sure that you got all of that. So, and then maintain continuity with you over the next 28 days via telephone. Here's a phone number, call me if something happens. That would be nice, sounds good. Okay, so this is a really busy slide, but it is about the 4 pillars and what would happen. So at the top, you will see medication self-management, patient-centered record, follow-up, and red flags. So these are all areas of what happens, what is the initial goal, what happens during the hospital visit, what happens in the home visit, and then subsequent telephone visit. One key thing I wanted to highlight, because it's going to go to our discussion in about 10 minutes, patient is knowledge, upper right. The goal in the hospital, before you leave, is red flags education. So patient is knowledgeable about indications that condition is worsening and how to respond. So let's say you're getting ready to leave the hospital. I'm just going to go back to this pneumonia example I keep talking about. You've been treated for pneumonia now. You're leaving the hospital, which is kind of a comfort zone. They have doctors there, nurses all the time. You're going home. Well, does anybody talk to you about, like, if it comes back, the fever comes back, the cough comes back, you start feeling dizzy, lightheaded, what are you supposed to do? So these are key issues. If it comes 3 days later and it's 3 o'clock in the morning again, and you develop a fever again, you're not a doctor. You were not trained to figure out, is this pneumonia failure now? Do I need a different antibiotic? You should have a resource, somebody to guide you through that. So that's the purpose of this. You call the phone number, you follow up. Hey, I was in the hospital a few days ago. Okay? So we're going to talk about that. This is their version of the patient personal health record. Important information. Again, highlighting some of the things I've already discussed. So family caregiver information goes on the piece of paper, so contact information essentially. And then the very right side, you see these red flags. So the care team in the hospital discovered that there are 2 or 3 red flags, for instance, for your condition. And they write them down for you, they tell you what you're supposed to do if these happen and who you're supposed to contact, okay? So this was studied in a randomized trial, so the Coleman transition model. There are a number of inclusion criteria, so I'm not gonna go into all of these, but the key part here is at the time, they were studying diagnoses that Medicare thought was a high likelihood that you would be readmitted to the hospital within the next 30 days based on their data. So these are the types of issues: stroke, congestive heart failure, coronary artery disease, heart attack essentially, cardiac arrhythmias, AFib, COPD, diabetes, spinal stenosis, hip fracture, and so on. These are conditions that Medicare knows and has known for 30, 40 years that these lead to readmissions. So what happened with this model? So these are odds ratios looking at whether you are likely using this intervention versus normal care, which is in a randomized control study, which is the highest level of evidence that we have in the medical world. There was if I can do my math correctly here, 41% reduction in your likelihood of having a readmission in 30 days. If you look at 180 days, that's 6 months, you had a 20% decrease in these readmissions in 30 days. So it's not perfect, but it's better. Again, looking at trends, we see something better, we want to try to accomplish that. Similarly, this is cost of care. It's not really relevant for this conversation, but there was a slightly lower cost. It's not dramatic, but slightly lower cost. So the summary, it's an intensive intervention, requires extensive healthcare system resources, so somebody's got to pay for these resources. These are not healthcare reimbursable. Your insurance company's not paying for these. So that was one of the big backlashes to this. The healthcare system leaders, the hospitals, said, well, hey, listen, we're getting paid for each patient that gets admitted. Not getting paid to keep people out of the hospital, so why should I invest extra dollars? So that has changed. There are now, after much legislation and patient advocacy efforts, we're moving in the right direction, but the wheels turn slowly. This is 20 years ago, and we are still just in the beginning phases of implementing some of these interventions. So keep that in mind. And also did not include high-risk populations, such as dementia patients, folks that are already living in nursing homes, okay? So.
What is LTC? Love tender
I'm sorry,
care?
long-term care patients.
Okay, I had it love tender care.
I should put that in there next time. So this second one is the transition care model by Mary Naylor out of the University of Pennsylvania. Similar concept. I'm just going to highlight a couple of the key differences. Transitional care nurse, they just use a different term, essentially the same idea, having another support person. In the hospital, they're comprehensive review of your everything, not just your medical condition, but your social history, what matters to you, okay? So the randomized study, Pennsylvania, hospitalized folks, this is now 1992, so we're, I guess, end of the Bush era, beginning of the Clinton era in some regards. So just intervention versus usual care. Same thing, inclusion criteria. I'm not going to go into this. I just want to show you again, they were targeting high-risk diagnostic admission codes. So folks that were admitted for heart failure, cardiac valve replacement, orthopedic procedures, hip fractures, those things. So what happened here? Same thing, 17%. They only followed, they followed people for 24 weeks. It's a pretty long time. It's almost 6 months. And out of their population in the intervention, 20% had one readmission in those 6 months. 11 of them, or 6.2%, had more than 2. So it was lower by 17% in terms of the readmission risk in this model. So why do I talk all about this readmission risk? So in the current context, in US healthcare politics, readmission risks matter, okay? Medicare and some of the payers have gotten really smart now, and they will penalize healthcare systems that do not invest in resources to decrease your readmission risk. Okay, so this is the new trend now. You have heard CMS, Center of Medicaid Services. They are, in fact, initiating these penalties. They will become more severe over the next 5 to 10 years. So it's not going away, but that's why this readmission idea makes a big difference. So this is, again, just a graphic illustration, time to first hospital readmission. So this is almost like it's a Kaplan-Meier curve, but the idea is that you're starting at 1. The higher you are on this curve, the less likely you are to be hospitalized again. Okay, so 100% on the very top. By the time you get to 30 days, you see 132 versus 129. So key is it works. Keeping you out of the hospital, this intervention works. My only caveat, it's an academically affiliated system at the University of Pennsylvania with tons of resources. It's very challenging to put this system in place in rural hospitals in America or in a city with predominantly private health care. The communication, the resources, they're just not available. So that's the issue that we are currently struggling with. The last project I'm going to mention is Project Red out of Boston University. And you're going to see some similar themes here. There's a pattern to it, if you will. 4 main areas of focus, and I have 5 bullet points there, but you'll see why in a second. Self-management, medication reconciliation, discharge plan, expedited transmission of that discharge plan is 4B, and then patient healthcare records. So again, they used a nurse discharge advocate. These are all just fancy terms for the same thing. There's another person involved in your care whose goal is to keep you out of the hospital. Okay. This is what they call the after-hospital care plan. So similarly to the Coleman model, the Naylor model, you leave the hospital with a document in place that educates you and any subsequent healthcare providers about what happened, what changes were made, and what or who you should contact if anything happens. So again, it was studied in a randomized trial, and the only thing I'm going to mention, same concept as before, reduced readmission risk. Okay, they did look at some secondary outcomes, which is interesting here. I'm just going to mention one thing. The very last part there, when you finally did go visit the primary care doctor following your hospital, they asked a couple questions. How well were your questions answered before you left the hospital? Surprisingly, even in the usual care, 62% of the patients said that their questions were well answered. My personal experience is probably about 10 to 20%. It's very, very low. Okay? So again, this is a controlled study. You have to give consent to be in the study. So it's, it's not a great example of what happens in every day, but it's out there. Same thing, how well did you understand your appointments after you left the hospital? 80% of the usual care group reported that they know exactly which appointments they're going to go to in the next 30 days, and they know exactly who they're going to see.
Right.
Not sure that that happens on a regular basis, just so we're all on the same page. Again, cumulative hazard ratio for those, if you're getting re-hospitalized, you have a hazard or a risk every day that you're out of the hospital of being hospitalized. So that's illustrated here. I'm going to skip this slide for purposes. I'm going to move to my consensus slide about what is important during a transition. So you've heard a lot of different themes. Number 1, number 2, 1, 2, and 3 could essentially be the same, but I told you earlier, medications was number 1, communication was number 2, and then the other issue is your own self-management. So the title of my talk is How to Be Your Own Healthcare Advocate. You know yourself, you know the history that you have gone through, you know who your primary care doctor is. So we need to do a better job as a healthcare system to empower patients to take care of themselves. Okay? So the idea of patient caregiver self-management, coaching, using teach-back method, instead of just reading you a long list of things, they should be asking you, okay, I just told you which antibiotic you're going to be going home on what dose and how frequently you're going to take it. Can you repeat back to me, what did I tell you? So if I just say, you know, well, Mr. Smith, you were hospitalized for pneumonia, you just need 3 more days of levofloxacin, 500 milligrams, acute daily, call your primary care doctor if you have any questions. Bye. It's probably not the greatest discharge instructions. I should probably pause for a few minutes to see if you caught all of that information. So, and then the last part is the importance of interdisciplinary team members. So unfortunately, many of the doctors in the hospital are very busy. They're running around, some of them are seeing 30 plus patients a day. It's very challenging if they're asked to do all this by themselves. So as you saw in these trials that were done, an extra person was added to help. It's not to take the responsibility away from the doctor, but to be successful, we need additional resources. So that is why most of these include some person, extra person. So I promised you that we would leave this lecture with some actual take-home message, or how you can improve the care for yourself or a loved one. So include spouse, any caregiver, anybody, family member, stranger. You know, you can tell anybody these tips if they will listen. So my first slide here is a couple of advice topics that we routinely provide folks on discharge from a skilled nursing facility. So 70% of my work is to see folks when they leave the hospital in our 13 different nursing facilities across Richmond area. So if you choose, after you leave VCU, to stay in our partner, the geriatric division, we'll try the best we can to follow you after you leave the hospital. So number one, you are only as healthy as you want to be. Okay? Now that sounds kind of like cliche, but we can provide you resources. I can talk to you. But at the end of the day, you know, I can't go home with you. I can't make sure that you get those medications. You know, I can't call the pharmacy at 12 o'clock to make sure that you picked up your medication. So we have to empower ourselves to take care of ourselves. And it's challenging. My caveat to that, I will say, if you recognize depression in yourself or others, or problems with memory, mood, depression, please ask for advice, okay? Please seek attention. Now, this is not something that you should be going through by yourself. If you're struggling with this, you need to ask for help. The second part, understand your own health. You should be asking questions, which goes to number 2, 3, and 4. When you leave that hospital, don't feel bad if the doctor turns his back to you and is about to walk out the room without having answered your questions. Speak up. Hey, doc, I got a question. 99% of doctors will come back to the bedside and answer your question. They just don't understand that they are being too quick. They want to help. They want to help you. But sometimes they don't understand that they're in such a hurry that they only spend like 45 seconds in that room. Okay? But they want to help. Most people have good intentions. Ask questions. Build a relationship with your doctor. So this is the importance of continuity with your primary care doctor. So you have a relationship with your primary care doctor. Even if you're in the hospital, call your primary care doctor. You could let them know, hey, I'm in the hospital. You'd be surprised. Some of them will call you back and say, hey, I heard you're in the hospital. You know, I might be there tomorrow. Will you be around? Maybe they'll stop by. They can't always impact your care in the hospital related to credentialing and other issues, but they could stop by and see how you're doing. So call your primary care doctor's office.
Would be nice.
Yeah, I'm describing the ideal and where we are moving in the next 5 to 10 years. I understand that.
less time with each patient.
I understand there are some challenges, but
Pay them, they should take more time.
there are many different ways to tackle this issue, but you will see as the healthcare market and the financials understand the stress, the models will emerge to support all included, including the patient, the doctor, the healthcare system. We're just turning the wheels a little bit too slow. Last thing, bring a friend or a family member. If you go to the ER, if you go to the hospital, or you're told the day before you're going to be discharged tomorrow, try to have a family member, somebody else there to help listen and be able to remember what everybody told you in the hospital. So that's important. It's really hard to do by yourself. So the last part I wanted to talk about is this idea of a healthcare journal. So out of show of hands, how many people write down either in some kind of journal format, whether it's just on a scrap piece of paper, or at least you keep a medication list somewhere that you might strike out things, you cross them out, you do some kind of notes. How many folks do? Okay, good. So we saw probably about a quarter at least, or maybe more than 40% of the room. So that's better than most people that get hospitalized. You get already ahead of the game. Thing I want to just illustrate in the second bullet point here, if I am seeing you in the ER as a doctor trying to understand what you have been through, these are the categories that I am asking about. Okay? Your past medical history, your surgical history, your family history. Family history, mainly we are interested in heart attack, stroke, cancer, those kinds of things. They're not so important in the acute issue, but important for your primary care doctor to track. Social history. Now, I will say that different doctors are better than others about eliciting and asking questions about your social history. It includes more than just, do you smoke? Do you drink alcohol? Okay. Good social history includes, where do you currently live? Who lives with you? And more importantly, do you need any help at home? So are you a independent person that lives by yourself? You don't require a walking aid at all. You take all of your medications by yourself. You don't need any reminders. That's very different from somebody that is starting to use a walker, a cane, requiring more assistance. We need to understand that when you come to the ER, because we need to put you in touch with resources to help you get better quickly, okay? So these are things that you should try to help illustrate. So the last thing is, or the last three things, your physician team, so your outpatient team. So you should have a list of at least 2 of your most important doctors. So your primary care doctor, number 1. But if you have, let's say you have an extensive heart history, and you see a cardiologist 3 or 4 times a year, we need to know who that is, because that's something that's really important. They have a lot of information about your heart function. We need to know that in the acute setting if something happens to you. Similarly, if you have chronic kidney disease and you're on the verge of maybe requiring dialysis, we need to know that. We need to know that you have seen a nephrologist and who that is, so we can communicate with them. The last 2 things are the ones that have been reiterated multiple times. Medications, this is the first time I mentioned allergies, but goes along with it. Your pharmacist will always ask, do you have any allergies if you're a new patient to their practice? And the pharmacist, that you're picking up medications. We need to know. Okay, this is one example, not a particular company or anything. I'm not endorsing anything. In fact, this one doesn't even have a company, but this is, the idea is for you to write it down. Now this seems like, a big binder, like 3-ring binder. You don't need that much information. But this is actually not a big binder. It's actually only about 6 to 7 inches by 3 or 4 inches. Pretty small, but it has these pages that will help you write down and take notes. Okay? The one I handed out to you all, the handout, the copy. So this is from the National Patient Safety Foundation. This is what they determine is important information for you to keep in your wallet. Something called a wallet, medication information wallet card. So if you look at this, the biggest box is dedicated to your medications. That is because my original slides mentioned that medications cause adverse events. Let's say, for instance, I'm going to throw an example out there. You're a heart failure patient and you are on Lasix or furosemide. The number one most important thing that we need to know when you come to the hospital is your daily dose of Lasix. If we don't know that, you could be overdosed, your kidney function could suffer, your potassium levels may drop. There's lots of issues if we don't know accurate medications. That's just one example, but let's say that you were on 20 milligrams of Lasix once a day, and in the hospital, all of a sudden you're discharged on, say, 80 milligrams. Well, if we didn't know what you were requiring, maybe we didn't ask you. So you should keep that information. Oh, hold on a second, I was on 20 milligrams before, now I've got discharge papers that say 80 milligrams. Can you please explain? Might be necessary, there might be a reason for it, but important for you to know. The other things, as you see, and the way they did the medication, there's different columns. I'll just read them. Name of medication, dose, how often and when do you take them, and then how do you take it, with or without food, and then the last column is reason for taking this medication. So you should be able to tell us why you're taking each of the medications that you're taking. Okay, so back to that patient information, patient advocacy, education. We need to make sure that you understand why you're taking your medications. And then allergies is in there also. So the way, if you don't have a card already in your wallet, the way to do this, it will show you a dotted line where you cut it out, you fill out the boxes, and then you fold it into essentially 4 columns. It looks like a business card. It's folded up after this is done. There's a variety of different formats. You can get them at CVS, Walgreens. Some pharmacies are now even sending out cards that have your medication list on them. You can ask your pharmacist for that. They may charge a small fee, but some of them are now printing out medication cards that you can carry with you. So, important thing to keep in mind. So, as we go through last 1 or 2 slides here, communication and information are key to successful transitions. Communication includes you talking to all your providers, and in the acute setting, you are not responsible for coordinating everything yourself. All we ask is that you ask the questions. And if we ask questions, if you have information available, if you could share that with the team, it would be helpful. So I'm not advocating that you should be doing everything. You go into the ER and now you're all of a sudden calling up your cardiologist because you're in the ER for chest pain. It doesn't quite work like that. I appreciate that extra effort, but the ER is there to help you with that. You are not there to design your own medical care, but you should be keeping in the track of that information. The information I'm talking about that is most important is what I talked about, the medical history, your medication list, allergies, emergency contact information. The last part I didn't discuss specifically today is advanced care planning. If you have specific goals and preferences about your care, if you have a durable do not resuscitate, if you have a living will, these are important documents to keep readily accessible. I'm not saying that you have to walk around with your living will of 15 pages long every time you go to the ER, but if you tend to go to a ER or a hospital system on a regular basis, be it any of the ones in town, Bon Secours, HCA hospitals, VCU, at least one time you should present your living will so that it's uploaded into the system. It is important in case something was to happen to you in the future and you are not able to talk for yourself. These documents serve as a reminder of your wishes, not some other person's wishes, not a random emergency room doctor at 2 a.m., but your wishes written down about what your care should be. So it's important that that information be available to those people that need it. So, key issues again. I feel like I'm just kind of reiterating these things. There is a theme to it, so I apologize, but I want to make sure you get some time for questions. So, hope you enjoyed the talk. Thank you all for listening. Nobody interrupted me or walked out, so I appreciate it. Thank you all so much.